the next evolution in blood storage solutions. Key for any modern pre-hospital blood program.
Contact Delta Development today and learn more.
What's your emergency?
My husband cut his arm with a power saw. He's bleeding so much.
Okay, what's your address? All right, I've dispatched an ambulance to your location. I want you to stay on the line with me until they arrive.
I could see that there's a major gash in my arm. I didn't know what had happened at the time, and I can't say that I felt a great sense of pain immediately. I knew with the amount of blood loss that I was seeing right in front of my face that if I didn't make it back into the house, that I wasn't gonna make it.
I woke up and started hemorrhaging from my miscarriage, and I didn't know what to expect from a miscarriage, so I didn't know that maybe I was in a very bad place and in a medical emergency. So we called 911, and by the time they got there, the paramedic told me that I had about a minute or two before I had died.
Our medical directors really work under the philosophy of, if it's being done in the emergency room, can we bring that same level of care, those interventions out to the streets, out to people's homes? A lot of data will tell you that the leading cause of traumatic injuries is hemorrhage, is bleeding to death. So we wanted to create a system to fix this issue.
In 2018, the city of San Antonio, Texas, launched a cutting-edge program that enables certain paramedics to carry blood on the ambulance and administer transfusions to acutely hemorrhaging patients. Since time is the enemy, the power to transfuse at the point of injury and en route to the hospital can greatly increase a patient's chance of survival. This capability is well within the paramedic skill set.
The evolution of EMS interventions is really honestly remarkable. If you rewind maybe 15 years, the idea of a 12-lead EKG was pretty rare in EMS circles. That was a hospital-only intervention. Cardiologists and doctors did that. And EMS did adopt that very successfully in the last decade or so and have seen great strides. Prehospital blood, I see, is the same caliber, if not even more, with the life-saving capabilities that we've had.
The standard for treating trauma patients in EMS is to administer crystalloid solution, normal saline in lactated ringers. The recent push for civilian whole blood programs was inspired by tremendous advances in trauma care in the military. Blood has been transfused on the battlefield for centuries, but in the 1970s and 80s it became cheaper and safer to use blood components: red blood cells, plasma, and platelets. Now, they are back to administering whole blood.
You know, right off the top of my head, I go all the way back to like World War II. Like, we were giving transfusions in the field back then. We knew that whole blood is the best thing for a bleeding trauma patient. But as things happen in wars and in that interwar time period, you lose some of those lessons. So it really wasn't until it came all the way back around with our conflicts in Iraq and Afghanistan that our special operations people started to say, hey, we need a product that we can give to our sickest trauma patients in the field. And so they started looking at whole blood, whether that was a walking blood bank, you know, human to human type transfusion, take it out of one person, put it in another, or if we could extend out the life of a unit of whole blood and store it appropriately. So they started developing that in the middle 2000s and early 2010s to be able to transfuse whole blood in the field. The injuries that were being sustained, it was no longer simply small arms it was more blasts and IEDs and things like that. And so you'd have more catastrophic injuries on the lower extremities, and you'd have obviously massive bleeding if you injured one of those arteries. But then there was also the distance. We were operating very remotely. We were in a counterinsurgency type operation, so there's no longer a forward edge of the battle area. The entire country is the battle space, so you have very remote groups doing patrols and very far away from advanced medical care, so they really had to bring that forward, whether that's moving surgical teams closer forward and then even moving blood even further forward to the point of injury. So it's really a time and a distance type thing that made that a necessity. And once we realized that they could do it there, then that started opening up, the whole labyrinth of where else could we use whole blood, and that's kind of where the pre-hospital environment here in the United States came from. A big name in this is Don Jenkins, but he was doing stuff up with the Mayo Clinic. He's a former Air Force surgeon, trauma surgeon, so he knew all those lessons. He knew what was doing good down there. Then when he moved down here, he started saying, hey, we should do a whole blood program here in South Texas. And I think that's where most of it came from, was really the power of those military trauma surgeons leaving the military and looking for a way, how can we take those lessons we learned that have been bought and paid for with America's sons and daughters and figure out how do we save people here in the United States. One of the reasons why here in San Antonio we have such really just a gelling of pre-hospital care and military care is because we do have things like San Antonio Military Medical Center, or it's also known as Brooke Army Medical Center, which is kind of the flagship of Army medicine.
San Antonio is known as Military City USA, and that's the fact that we have so many military installations around here. Nice mix of Army, Air Force, and some Navy. And as a result, in this area, a lot of military veterans live. Either after they've gotten out of the military or they've retired. So we started from the position of, yes, we could do this. We just need to figure out how to take those military experiences and make them work in the civilian environment. So we've got a blood center who's willing to supply the blood. We've got a pretty evolved trauma system here in South Texas. So why can't we do this? And the answer was, clearly, we can.
Scott Mussey was one of the first civilian patients to benefit from this combat-inspired capability. He experienced a catastrophic injury when a power tool he was using slipped and sliced open his arm. Fortunately, his wife was also home at the time.
I hear what I can only say was just a pop. My injury was right here on my arm, and this is just bleeding badly, and I'm soaked in blood at this point. So she couldn't exactly see where my wounds were, and she put an immense amount of pressure with that towel on my arm to help slow the bleeding as much as she possibly could. At the same time she's talking to 911, they could hear the panic in her voice, so they rushed an emergency EMT crew as quickly as possible to get to me. In my accident, I ended up severing both brachial arteries. I had some extensive nerve damage, and my surgeons did everything that they could do to repair the nerve damage as well as the cardiovascular injury that I had. With respect to my injuries, I had to have some skin grafts, and you can see here I've got some issues from some cool scars that I can make up stories if I needed to. I think if my accident would have been in many other cities or many other states, my outcome would have been differently, and I wouldn't be here today.
It can be challenging to design and implement a successful blood program. Collaboration and communication among the key players is crucial.
It has to be a team sport. There is no other life-saving intervention done in the pre-hospital setting that requires this much collaboration. If an EMS agency wants to buy a new defibrillator, they just find one they like and purchase it, train on it, and put it in an organization. You don't need to go to the hospital and ask permission, talk with other clinical services. But blood is very different because it is a highly regulated item that you have got to go talk to the blood centers. You have to get their buy-in. You have to talk to the hospital because there is an administrative tail not just the clinical tail to using blood products in the US.
A big part of that administrative tail takes place here at the South Texas Blood and Tissue Center, where blood stewardship begins. Donors with the blood type O positive give regularly and specifically for the pre-hospital supply through a program called Heroes in Arms.
So blood that we collect from Heroes in Arms donor goes to pre-hospital and is used or not used up to 14 days. And if it's used, that's great, we just replace it. If it is not used, that blood is then brought back to us and then taken to University Hospital. So we work with the South Texas Regional Advisory Council, STRAC, and a number of pre-hospital entities. That includes San Antonio Fire Department, a number of air ambulances. I think the biggest challenge was just getting everyone in the room to understand the expectations of setting up a program like this, because the program is really revolutionary in that we have this blood being moved in so many different ways across the city, right? Helicopters, for example, are getting blood that they never had before, right? So it's a lot of logistics in trying to figure out what are the requirements to actually having that blood on the helicopter. The other logistics is just making sure that you have enough donors. As blood centers, we struggle across the country with getting enough donors through our door to collect enough blood for local patients. And it has just been a challenge. And so you want to find a way to motivate donors, right? Because we do struggle, especially with certain age groups, in getting those donors to donate. And then making sure that once we do collect that blood from that Heroes in Arms donor, that it is used. The wastage we have is less than 2%, which is really great for any sort of blood product. I think it just really is the partnership. I don't think the wastage would be that low without having the partnership with pre-hospital and with University Hospital, who's the end user of all of that blood. Donor show rate and frequency are much higher in the Heroes in Arms donor base versus the rest of the donor population. I think it is because of the messaging that we do to that donor base, that your blood will be used in the pre-hospital setting. And I think it does give the donors a sense of urgency and a purpose, right? Because they see their blood being used or in transport all across San Antonio.
Strict storage guidelines ensure that these blood donations remain viable.
So when whole blood is used in the pre-hospital setting, the pre-hospital entity, whether that's an ambulance or an air ambulance, is going to give us a call to get that blood replaced. And so what our hospital services reps do is they replace it. And first they come to the refrigerator that is 1 to 6 degrees Celsius, and they pull out the whole blood. So whole blood, the volume is around 500 mils. And you can see in the whole blood, it has different layers. So whole blood is plasma, red cells, and platelets. It's everything, right? And you can see the layer of the plasma, some platelets, and then you have the majority of the unit being the red blood cell component. And then we have the blood type of the unit, which is O positive, the expiration date. And then we also have temperature monitoring on some of the units that I can show you as well. So blood in storage should be kept at 1 to 6 degrees Celsius. And for transport, it's 1 to 10 degrees Celsius. So you have this tiny little temperature monitoring here. And so if it goes above 10 degrees, the circle in the middle turns red.
At Fire Station 15, Lieutenant William Bullock also follows stringent protocols to preserve the blood's integrity.
The way our system works, and I think a lot of EMS agencies do, is it's a 2-cooler rotation. So every 24 hours, we pull an empty one out of the freezer. We pull this one here that has the blood in it off of our vehicle, which is where it normally is housed. We open it up. We're going to take our lid off. We give our blood just a quick visual inspection to make sure it looks okay. We look at the temp dot to make sure that it's green and white, which means we haven't got too hot. It's all within proper parameters. It's got the right blood markings on it. It's got its tag, so we're good to go. We're gonna switch this over. We don't need to be super fast with it, but we don't wanna let it out for too long. We've got something here called a temp stick that we keep in a plastic bag because the humidity really eats up the batteries. But this little device right here will allow a third party or myself or my med director or our blood center to know what the temperature is in this cooler at all times. So we've got 24 hours of fidelity on exactly what the temperature is with this blood unit in the cooler. So this lives next to the blood at all times in the cooler. We're gonna put the fresh thermal insulator in, take the old one out. It gets exchanged, lid goes on. It's a little vacuum seal with that lid, Velcro down, and then we've got our tote bag canvas cover, if you will. Then inside here, I've got my receipt from the blood center, and I've also got an informative card that can be handed out to the hospital in case they're not familiar with the program. They can look up exactly what we're doing. Also gonna check our warmer real quickly, part of the daily check. We just open it up, we're gonna pull it out. We're gonna turn it on. Little switch in the back, just goes down. And now we'll see the battery, looks full. Make sure the disposable unit is there, as I'd mentioned. And in no way compromised, the package looks good. So in San Antonio, EMS covers 480 square miles. We've got a population of about 1.6 million people, but during business hours will swell to close to 2 million. And for that populace, and we run about 200,000 EMS calls a year. Typically we transfuse about 300 units of blood every year. So not a huge percentage of our calls, but very, very serious critical patients are the ones that receive this. We've got 8 units of blood at any given time that are available for transfusion. So any patient in hemorrhagic shock, as determined by our paramedics and EMTs, and it could be from a traumatic origin, like a bad automobile accident where maybe someone has injured a limb or their thoracic cavity, or maybe from a cutting call, or someone that gets impaled with something, possibly a shooting, or medical origins, and that would be like a GI bleed, maybe someone's got esophageal varices, a condition like that, or an OBGYN call. We've had a lot of women in childbirth that have become hemodynamically unstable and they needed blood for themselves and their baby. So in those instances, when maybe the baby's born or the baby's born a few weeks later, we kind of count that as a double save because two lives were saved at that time. All of our paramedics are trained to what we would call like an awareness level or awareness standard. So they have the understanding of what calls are going to necessitate a blood transfusion, and they have knowledge of how to operate the equipment. But there's a select number of us where we would say like an operational level, and that would be the medic officers and our medical special operation unit paramedics. And those are your medics that do the tactical calls, like with law enforcement, and it could be San Antonio Police Department, it could be the DEA, the ATF, but they have a higher level of training. Blood would be part of that cohort of skills that they have. Our dispatch unit will send our whole blood capable units on certain call types. In our system, it would be for any call for a shooting or a cutting or a motor vehicle collision where someone is pinned, because statistically those are the calls that are going to need the blood. Honestly, there's a lot of violence here and a lot of big highways. It's a big city. We've got a lot going on. It's a lot of moving parts. Whereas if they have blood, maybe more in a bedroom community of a larger city where the population may be more geriatric, they may have more gastrointestinal bleeds. But given initial assessment on scene from any EMS unit or fire crew in San Antonio, they can request the blood at that time. Because interestingly enough, sometimes we give blood for a call that might come in as a syncope, which is fainting, or a weak and dizzy or something like that. And that's how it got called into the dispatch center. But in reality, they're weak and dizzy because they vomited a large amount of blood or something like that. We also see a lot of transfusions from OBGYN related calls. It's not an auto dispatch in our system, but a lot of the time we're gonna watch that call very closely because they may end up needing blood.
I was pregnant at the time. I was told that I had miscarried and that there was nothing they could do for me, that I needed to go home and just let nature take its course. About 3 weeks later, I was in bed late at night and I felt something kind of pop inside of me, and then I just started hemorrhaging. And I remember asking my husband to call 911, and he said, "Are you sure?" I'm like, I was told what to look for if I was hemorrhaging. I'm like, I'm pretty sure this is more than it's supposed to be coming out. But as soon as I got into the ambulance, I remember my paramedics being very efficient. They found my vein, told me I was getting a blood transfusion, and as soon as that blood hit me, I felt instantly like my brain came out of the clouds and I was back. It was a really tender moment meeting my donor. He told me that he started donating blood regularly because his wife passed away from cancer, and he saw all the blood that she was able to receive and wanted to pay it back. He got to see all of his efforts, that they weren't just nothing, that they really meant something, and this blood really does make a huge difference. And to be able to witness that he had donated just like a week before I got the blood, and to see what an impact that made, I wish that for everyone. There had to have been angels surrounding me the whole time. There had to have been. The paramedics, like the doctors who were able to come back, everything was just so in place at the right time. And it would never have happened without the blood.
We've been going for about close to 6 years, and we are right at 1,400 transfusions in that time. And it's kind of increased through the years as our first responders have recognized patients that might be in need quicker, so then they ask for the blood, on a more efficient basis.
That efficiency is invaluable when dealing with a large-scale event.
So in a mass casualty incident, a lot of your injuries are going to come from trauma. So with the blood, we're able to buy time for those patients that are critical before their arrival to the hospital. They've lost blood, so intuitively, what do they need? The blood that we have. In reference to Uvalde, 85 miles from San Antonio, so a pretty good distance, but in our system, we had blood transported from San Antonio, kind of the origin area, out to Uvalde via EMS units, and also via helicopter through our air medical providers. And the blood was able to be distributed right there to the school where the shooting was, or at the local regional hospital just a mile away. And really, when you talk about hemorrhagic shock and blood transfusion, time is our enemy.
When they arrive on scene, paramedics use the patient's vital signs to determine whether or not they should administer whole blood. To establish clinical guidelines on what those parameters should be, the Office of the Medical Director at UT Health San Antonio looks at the hospital transfusion data and at the diagnostic capabilities of the paramedics. It's an ongoing process.
The medical protocols were a little difficult to set up because I didn't really have anything to build off of. So I developed them from borrowing from various research projects, research studies, other things that had been done in the hospital. Not a whole lot pre-hospital. I borrowed the shock index concept from a couple of studies that were done in Pittsburgh and Denver, Combat and Pamper trial. And those basically say shock index of 1.2, which is heart rate over blood pressure, means someone is going to be pretty sick if they're in hemorrhagic shock. So that's one of the main core ones we use. We also have in San Antonio end-tidal CO2. End-tidal CO2 is basically a surrogate for poor perfusion. When you don't have blood in your body from bleeding out, you have poor perfusion. So we transfuse with end-tidal CO2. The shock index is mentioned. We also have some different indices for different age groups. If you're over 65, we're going to change that shock index to 1.0 from 1.2. So it's actually, since you probably need blood more if you're older and bleeding out, we'll give you blood for a lower shock index. There's also one that is still somewhat controversial that I came up with back in 2017, and that is we will transfuse blood to someone that has just died from hemorrhagic shock. That one, we've saved a life right away. That clinical operating guideline, that medical protocol, while I didn't have any frame of reference for it, I knew from being a paramedic for many years, patients that are trapped in their vehicle often have these smaller bleeds, a splenic laceration, a liver laceration, some type of gastrointestinal laceration where it takes an hour or two to get them out, they really just need blood, and of course the surgeons. But really they can live through that moment if we can just get blood back into them until we can get them to definitive care at the hospital. Is it actually good for the patient? And is it evidence-based medicine confirmed that what we've been doing is saving lives? So we have done some research on that. We know we are decreasing early mortality for our patients. So in the first 6 hours, if we can give them blood in the pre-hospital setting in EMS, then we know we can save their lives for the next 6 hours. It's really difficult to show you're saving lives for someone that is so critically ill. This is just one treatment among many that the patient often needs. Airway, stop the bleeding. Don't just put blood in, you gotta stop the bleeding. I'm an ER doctor as well as an EMS doc, and blood has been transfused in the hospitals for 100 years almost. But yet no one would ever do a study that compares transfusing blood into a patient in hemorrhagic shock versus giving them saline or doing nothing. So for me, yes, data is important. We'll get the data out. We'll eventually show that this saves lives. But also, I think it's been interesting for me to learn on this journey that hospitals have never done that research because they would consider it unethical. We certainly have case reports. We have individual patients we've saved. We've had case series of saving patients from trauma to medical, etc. And one day, soon, very soon, we'll have all that data compiled and we'll be able to show that this intuitive treatment is absolutely the right evidence-based medicine treatment for patients.
With concerns over insufficient blood supplies, it may seem counterintuitive to have EMS now pulling from that stockpile, but careful blood management can actually ease demand.
The earlier you can get blood in a patient, the less blood they'll need in the hospital. It's rather intuitive because the whole hemorrhagic shock concept is really a large part of it is an inflammatory response. You're losing your endothelium. I know it sounds fancy, but basically your blood vessels start to break apart. Your body starts to break apart when it doesn't have blood and oxygen. This inflammatory response, this lack of early access to a blood transfusion actually has many downstream effects, not just mortality, but morbidity. From needing more blood, which means more donors transfused into the recipient patient, and also just a longer time without the right product in your body.
There are many challenges to starting and maintaining a program, and the San Antonio model is not one size fits all.
Unlike almost every other state in the union, if not all 49 other states, Texas has a delegated medical practice. So if the physician says we should transfuse blood for those in shock, the paramedics can transfuse blood. The other real barrier is money. So it costs money on the front end to buy the warming equipment, to keep the blood cold, to buy the transfusing equipment. All of that in the blood itself costs money. And there's no reimbursement. And that's a real shame. There just aren't a lot of rules out there for us to know what to do in the pre-hospital setting when transfusing blood. So there are some new standards that are coming out from AABB. Some of those difficulties have been mitigated by borrowing from what the US military did to keep blood cold downrange. So we borrowed from the military. We have these super coolers that can keep blood cold out in 120 degree South Texas heat. Some other challenges and difficulties. Does it work? Is what I'm doing working? Am I saving lives? Data, research, that takes time, effort, money, financial resources that aren't really there to perform research. It's just my free time. Difficulties of knowing what clinical operating guidelines I should use. Still, I don't know where I should exactly choose the heart rate, where I should choose the blood pressure. Clinically, we've had these patients where they don't quite meet the transfusion guidelines, but they're bleeding out in front of us, vomiting blood, whatever the case may be. That patient needs blood. A few more are special populations, older, younger. One big population that I had a hunch that we would transfuse a lot and has always not thought about first, OB patients pre-hospital. That is a segment of the population that really should not be dying pre-hospital. They just need a little blood. Low titer O positive whole blood is nearly universal as a donor, but not quite universal. Low titer O negative would be the more universal. But as you know, there's just not enough low titer O negative whole blood in the world to even fulfill our needs in San Antonio. So we use the next best thing, which is much more common to have low titer O positive whole blood.
For those districts that cannot access whole blood, components are the next best thing.
So your bleeding blood, I think that's probably what you should put back in. One donor into the patient, all the right products. We're answering the questions of blood failure, and the questions of blood failure to me are oxygen debt, endotheliopathy, platelet dysfunction, and coagulopathy. Whole blood answers all of those questions, all of those concerns, all of those problems you have in organ failure. But I do think that if you have only plasma, or if you have only red blood cells, then it's better than saline or better than doing nothing.
All right, almost on scene of a fall, an elderly gentleman on blood thinners, so we're gonna investigate and see if maybe we've got some internal bleeding that he might need blood for.
You've got a lot of factors at play in an EMS system when it comes to choices of equipment and drugs and interventions and things like that. But we always walk back to what's best for the patient. What will be best for the patient? How do we save lives? We understand that it's a precious resource and we want to transfuse to the people that are in need, but we also don't want to hesitate. I feel like we've struck a great balance on identifying the patients that need it, being efficient, getting them the intervention, and then getting to the hospital where the doctors can give them definitive care.
I think blood is going to be one of those capabilities that, if operations pick back up, that the military is going to look to the civilian world on how are they doing it. You've got agencies like New Orleans, who is doing hundreds and hundreds of blood transfusions. Washington, D.C., hundreds and hundreds. Those medics are highly skilled and they're seeing complex penetrating trauma. So again, I believe it's a very symbiotic relationship that we need to continue to learn from each other.
There are absolute difficulties to recreating the success we've had in San Antonio and South Texas, no doubt. From financial to just we don't have this product to is anyone going to use this product? All things that make starting a program and keeping a program going difficult. But I don't have anything else in the pre-hospital setting. I have nothing else. I have normal saline, not good for bleeding patients, most likely not good for bleeding patients, or I can do nothing, which is, we made a fancy term for it, permissive hypotension. Now we have the treatment. Is it the perfect universal treatment? It's not. Do I have the data? Not quite. Do I think it's the right thing to do? Absolutely. I've staked my whole career on it.
I can't imagine having to say goodbye to my children without really saying goodbye to them. I have 3 others at home, and I'm holding my baby right now. This isn't the baby that I miscarried, obviously, but I was able to get pregnant again and have this baby. He's 6 months old now, and that would never have happened if I hadn't received that blood. That blood was so important to keeping me alive from point A to point B. I wouldn't be here without it.
I truly was in a fight for my life. And if they hadn't taken the steps that they took, in my personal opinion, to give me whole blood as well as saline en route to the hospital, the efforts that took place from my surgeons and all of my therapy team along the way after the fact wouldn't have been necessary because I wouldn't be here.